Hi, and welcome back to the Pro PA podcast. I'm Angie Urbina, your host for this cardiovascular series. Today we're tackling orthostatic hypotension, a common condition that can sometimes be overlooked. We'll break down the kinder patho, who it affects, how it presents, and most importantly, what you can do about it. We'll wrap up with some clinical pearls and questions to test your knowledge. Let's get started. So what exactly is orthostatic hypotension? By definition, it's a drop in systolic blood pressure by at least 20 millimeters of mercury or diastolic pressure by greater than or equal to 10 millimeters of mercury upon standing or assuming an upright posture. Normally, when you stand up, your body compensates by constricting blood vessels and increasing heart rate to keep blood flowing to the brain. But when these reflexes fail, blood pools in the lower extremities, and you feel dizzy or even pass out. Orthostatic hypotension can be neurogenic, meaning there's an issue with autonomic regulation, often seen in Parkinson's or diabetic neuropathy, or non-neurogenic, which is caused by volume depletion or certain medications like vasodilators and antidepressants. A related condition is postprandial hypotension, which happens 1 to 2 hours after eating because blood shifts to the digestive system. Who does orthostatic hypotension affect? This is going to sound a bit redundant, but the repetition may be helpful. It is most common in older adults, but it's also seen in younger individuals with conditions like autonomic failure, diabetes, and volume depletion. Certain medications like antihypertensives, diuretics, and antidepressants can also trigger it. And don't forget about dehydration, especially in athletes, the elderly, or patients with gastroenteritis. Regarding clinical presentation, orthostatic hypotension can present as dizziness, lightheadedness, blurred vision, weakness, or even syncope after standing. Orthostatic hypotension is diagnosed by comparing blood pressure readings in the supine and standing positions. Blood pressure is taken first with the patient in supine position after 5 minutes of rest, then after the patient has been standing for 1 to 3 minutes. The diagnosis is made if there is a reduction of 20 millimeters of mercury or more in systolic pressure, and or if there's a reduction in 10 millimeters of mercury or more in diastolic pressure. Other useful tests include tilt table testing for patients with an unexplained cause of orthostatic hypotension, blood work and an electrocardiogram to check for anemia, dehydration, or heart disease, a Holter monitor if there's need to rule out arrhythmias and detect structural heart disease, and autonomic function tests if neurogenic causes are suspected to ascertain abnormal baroreflex function. And just a quick note here, always ask about medications, fluid intake, and symptoms of underlying conditions when evaluating a patient with suspected orthostatic hypotension. Now, moving on to the management. This depends on the underlying cause. First-line treatment is always non-pharmacologic. You want to increase fluid and salt intake unless this is contraindicated. Encourage slow position changes when switching to standing from a sitting position. Compression stockings or abdominal binders to prevent blood pooling. Avoidance of large carbohydrate-heavy meals. Elevation of the head of the bed. Moderate exercise. And physical countermaneuvers such as squatting, leg crossing, buttock clenching, and leg elevation. Now, if symptoms persist, medications like fludrocortisone, metadrin, or droxidopa can be considered, but this is only when non-pharmacologic measures are insufficient to control symptoms. Regarding prevention, patients should stay well hydrated, avoid prolonged standing, perform leg crossing and muscle tensing before standing, and there may be need to adjust medications that contribute to hypotension. Here are some clinical pearls. Number 1. Patients should sit at the edge of the bed before standing to allow time for blood pressure stabilization. Number 2. Supine hypertension is a risk. Patients on medications like metadrin may develop high blood pressure when lying down. And number 3. Don't miss secondary causes. If a patient's symptoms are severe or persistent, evaluate for diabetes, autonomic dysfunction, or adrenal insufficiency. All right, let's practice some questions. A 74-year-old man presents with dizziness and lightheadedness upon standing, occurring for the past month. He denies chest pain, shortness of breath, or recent illness. His medical history includes hypertension and type 2 diabetes. Medications include lisinopril and metformin. Vitals are the following. Supine blood pressure is 135 over 80 millimeters of mercury with a heart rate of 85. And standing blood pressure after 2 minutes is 110 over 65 millimeters of mercury with a heart rate of 85. Physical exam reveals decreased sensation in bilateral feet, but a normal neurological exam otherwise. He also has good skin turgor and moist mucous membranes. Which of the following is the most likely diagnosis? Is it A, vasovagal syncope, B, orthostatic hypotension, C, postural tachycardia syndrome or POTS, or D, cardiac syncope? I'll give you a couple of seconds. If you chose B, orthostatic hypotension, you are correct. A drop in blood pressure of greater than 20 millimeters of mercury systolic after standing confirms orthostatic hypotension. The lack of heart rate compensation and presence of peripheral neuropathy suggests neurogenic orthostatic hypotension, which is commonly seen in diabetic autonomic dysfunction. Question 2. A 50-year-old woman presents to urgent care with dizziness and weakness for the past 2 days. She reports multiple episodes of vomiting and diarrhea after eating at a restaurant 3 days ago. She denies fever, chest pain, or shortness of breath. She has no significant past medical history and takes no medications. Vitals are the following. Supine blood pressure of 128 over 78 with a heart rate of 100, and standing blood pressure after 3 minutes of 98 over 60 millimeters of mercury with a heart rate of 110. Physical exam reveals dry mucous membranes, no neurological deficits, and no lower extremity edema. Which of the following is the most likely cause of this patient's symptoms? Is it A, volume depletion-induced orthostatic hypotension, B, Addison's disease, C, postural tachycardia syndrome or POTS, or D, cardiac syncope? If you chose A, volume depletion-induced orthostatic hypotension, you are correct. This patient has acute gastroenteritis with dehydration leading to orthostatic hypotension with a compensatory tachycardic response. Unlike neurogenic orthostatic hypotension, which lacks a heart rate response, her increased heart rate supports volume depletion as the primary cause. Great job! That's a wrap for today's episode on orthostatic hypotension. We covered the basics, the key diagnostic clues, and how to manage it in primary care. If you found this episode helpful, don't forget to subscribe and share it with your classmates and colleagues. And as always, this is the Pro PA Podcast, where future pros in medicine are made. See you next time.